Hello and welcome to On Call After Hours, where we try to, between popcorn, answer the questions we weren't able to get to during the broadcast portion of our show. All of your questions are important to us, and we want to answer as many as we can for you. So let's dive into it. 86-year-old atrial fib after 80-year-old doctor wouldn't didn't want to shock her or him after 80. Is this standard procedure?
There's no real standard for who gets cardio. It's called a cardioversion to shock your heart back to normal. I kind of base it on a lot of things, really, looking at your echocardiogram and things. But like, do you have symptoms or not related to the atrial fibrillation? If it's uncertain, I'll do a cardioversion just to kind of see how you feel. Because really, getting back into normal rhythm is all about symptoms. It's not about living longer.
And there's a price to pay. If you get them back into rhythm, you got to go on these drugs that drag you down.
Sometimes, yeah.
At 80, it's generally not appropriate to do that defibrillator to bring you back to a normal rhythm.
And
that's not to say you wouldn't do CPR, right?
Yeah.
We're not talking CPR. We're
Yeah.
talking about bring it to a normal rhythm.
Yeah, so I don't, I don't have a hard and fast rule. There's no standard, like I said, but the longer you've been in atrial fibrillation, the harder it's going to be to keep you in normal rhythm. And sometimes we do it just to see if you're really having symptoms or not related to the atrial fibrillation. Yeah.
This is yours, Ray. My sister has a heart murmur and she takes antibiotics before getting down to work. Are we still doing that?
Almost not at all. We've sort of gone 180. If you've had a heart valve infection previously, then yes.
If you've got a mechanical valve.
If you've got a mechanical valve, then yes.
And that's fine.
Actually, it's prosthetic valve.
Yeah. So it's, whether it's tissue or mechanical.
Oh.
Yeah.
So if you've got an artificial valve, that's it.
Yep. If you've got a prosthetic and if you've had a valve replacement procedure, you get it. If you've got congenital heart disease, you get it. Or if you've had a valve infection before, you
But
get
not
it.
with a murmur anymore.
Nope.
We're done. That's changed. And that's within the last 5 years.
Correct.
60-year-old caller wants to know the effects of Viagra on the heart. Ray, that's yours.
It was designed as a heart drug and sort of as a side effect. It's labeled dose now, but I don't think there's actually too much effect on the heart. There's more of a concern that people will get into trouble. The big problem is nitrates, and what it does is it reduces the metabolism of nitrates. So if you have chest pain, take a nitroglycerin, you may get a very profound drop in your blood pressure, so it's dangerous.
Some people use Viagra. They name it differently, but for high blood pressure in the lungs to help the right heart function. So in some ways, it can be good for the heart.
Right. So,
But most people don't take Viagra for that reason.
some people use and Cialis and Levitra. All of those have a dilation effect to the coronary arteries, and that was the original the reason they were developing them. But now we're using it for pulmonary hypertension, and we're using it for people with prostate problems. So there's, the last, it's raising a lot of more questions besides just other things that it's raising. 22-year-old, what is a sign of tachycardia?
The most common one is palpitations. People just talk about, and palpitations is just I feel my heart pounding in my chest, my heart racing. You might feel lightheaded.
So tachycardia
Yep.
is fast heart rate.
Yep, fast heart rate.
Can be from a lot of different kinds,
Yeah.
including atrial fib, and that's the next question. What causes atrial fib? And I answered that really on the essay.
Well, really it depends on how deep you want to get into it, but that'd be, the million-dollar question for us as electrophysiologists.
What's the most common?
Well, so the conditions that are associated with it, the risk factors are, big one is age. The correlation with age is almost goes up exponentially as you start to hit your mid-60s and go into your 70s. 6% of people over 65 have atrial fibrillation. But then uncontrolled high blood pressure, stiff heart, history of a heart attack, heart failure, thyroid problems can cause it, other drugs can cause it. Alcohol, believe it or not, a lot of people, I've seen it all the time. People come in around the holidays, Super Bowl, they come in and they drink a lot of alcohol and they have more atrial fibrillation.
So a lot of different
Stimulants, yeah.
That's part of our job, figure out why they did this. 78-year-old from Jefferson wants to know if there are generic blood thinners, alternatives for the very expensive drugs.
Coumadin is the only generic blood thinner out
And
there.
it's much cheaper than all the rest.
It's very cheap, but you have to have your blood tested all the time. And it interacts with a lot of other
I'd have to look in the PDR, but actually Coumadin's a brand name, is not.
But warfarin.
Warfarin.
There's a generic version of
Right.
Coumadin.
Warfarin.
right,
Warfarin is the generic.
All the other ones are brand name only.
Right. And statistically, looking at all the data, it's about as safe and it's about as effective as the others. Disagree or agree?
Disagree. So the difference is Pradaxa or dabigatran and Eliquis, apixaban, are both shown to be superior to Coumadin for reducing your risk of stroke. Pradaxa has more GI bleeding relative to Coumadin, and Eliquis has less GI bleeding and less intracranial bleeding than Coumadin. Now the difference in how superior they are is not much.
Less than a percentage.
And the reason for that is because if you take your medicine and you're taking Pradaxa or you're taking Eliquis, apixaban, your blood is thin consistently. Whereas Coumadin, there's this thing called time in therapeutic range, or how often is your blood really thin enough from your Coumadin, and it's usually about 65 to 70% of the time in any trial that you do. It's because it's hard to manage. It goes up and down, the INR does.
I guess I'm a warfarin man at this point. Not to say that I'd always be.
Well, so the disadvantage of the new ones is there's no antidote for any of them.
There you go.
So that's a big
And
problem.
you can't monitor whether they're taking it.
Can't monitor.
It's
yeah.
the most dangerous drugs. They're the most dangerous drugs that we prescribe, and I can't prove that they're taking it, except I can with warfarin.
Heart valves, Coumadin only at this point. They
Yeah.
did a trial with trying to see if Pradaxa would, and it actually was worse.
That's important information. Comments?
I agree.
92-year-old caller from Rapid has a pacemaker placed 2 years ago, has hot flashes from elbow to elbow across his chest. Related to the pacemaker?
That would be really an unusual presentation. I've never seen that myself.
Something in their spine. It's a back problem.
It sure sounds like it. Depends on how they define flashes.
Yeah. Yeah. It could be coronary disease, I suppose. He's 92. You never know what 92-year-old. My guess is it's cervical spine impingement. Does walking count as helpful exercise toward the 20 minutes suggested per day?
Yes.
Absolutely. 57-year-old from St. Paul, what would cause a tightness, pain in my chest after a brisk walk and a large meal? Ray?
That'd be coronary disease until proven otherwise.
Yeah. So what's the next step?
Well, depending on the situations and how much exercise, you could do a variety of things, but an exercise test.
You know, there's some argument, though, because if you've got classic angina, the exercise test isn't going to change what you're going to do. The exercise test is to decide whether you're going to go, I'm going to send him to Ray Allen to do an angiogram.
It goes to the heart of over-testing and what's an appropriate test in a setting, and sometimes we've swung too far, because in the old days we would say new angina, sounds like angina, let's do an angiogram. And now a lot of times insurance companies would demand that we do another test, whereas in the old days we would have saved them a test.
Yeah, it depends. And it depends upon that case. That guy needs to see the doctor, talk to her or him about the symptoms.
And there's other ancillary questions you'd ask.
Yeah.
How long does it last? Short of breath, sweaty,
Yeah.
those sorts of things.
Right. I have been diagnosed with atrial flutter, not fib.
Yep.
What's the difference?
So atrial flutter, I don't know if we can still use this thing, but atrial flutter is a more
Yeah.
organized rhythm, more confined to the right atrium, where you kind of have this reentrant circuit in the right atrium. And when we ablate that, we burn an area from this IVC, inferior vena cava, to the valve, and then that stops it.
It stops it.
Yeah.
Okay. So
Kind of on the same spectrum. There's still a risk of stroke. We treat it like atrial fibrillation in terms of risk of stroke, and about 30-40% of people with atrial flutter end up with atrial fibrillation later on.
yeah, good. That's interesting. But this one's not.
It's much more organized.
It's more on the right than it's on the left. That's interesting.
There's all kinds of anatomy that John knows that nobody paid attention to before.
Back in the old days.
Internal anatomy
Until
and
you're trying to-
landmarks.
Until you're
and
trying to ablate it or not ablate that.
That's why you had 2 extra years of fellowship. Could you talk about the issue of ventricular hole that's been diagnosed in a 5.5-year-old girl, telling her parents that this could close on its own? They hear a heart murmur, feel that she could have Goldenhar syndrome. Does that relate to the heart issue? Congenital birth defect involving deformity of the face. So there's a facial deformity, and there's this heart murmur. It sounds like a VSD, a ventricular septal defect. Does it ever close on its own? Do VSDs close?
The pediatric cardiologist would talk about whether that's a restrictive VSD or an unrestrictive. And basically, restrictive would mean that it's small enough that there's a pressure gradient across it. And typically, if there's a large pressure gradient, those will often, at small, those will often close. But that's, again, a whole subspecialty unto itself.
And if the pediatric cardiologist said it will leave it alone, then it's probably leave it alone.
They probably know what they're talking about.
What about holes in the atrium? Via ASD, atrial septal defect, or patent foramen ovale. You know, for a while there, we were plugging those all. We're not doing that anymore, are we? Some of them.
I think it's an unknown.
Yeah, patent foramen ovale is when a little flap from your right upper chamber.
All right, so let's do that.
So patent, you can't really see it here, but just imagine that there's a line here dividing the two upper chambers, and there's this little flap here that you get when you're born. It closes and then seals off the connection between the two upper chambers. But in about 25% of people, that does not close, and so blood can flow between the left upper and left and right upper chambers of the heart. And so it's thought that that may have it may have some implications with stroke, and it's been thought that maybe some people with migraines, if you close that helps. And so it's been really difficult to know who exactly to close that for. Like Ray was saying, it's been kind of controversial. No real good trial data to really say one way or the other. I'm not, that's not my area of expertise.
But it's, go ahead.
Yeah, and an ASD is not a patent foramen ovale. That's just an actual hole in the actual atrial septum. So there'd be like a hole up here between the two, and those often don't close on their own.
Right, and you make that diagnosis how, Ray?
Listening, EKG, and the gold standards in echo. You look
You
at image it.
Do a little bubble study.
Yeah. And if the right heart is getting enlarged or having showing some dysfunction, that's usually when you decide to close that.
And in the old days, when the only way to close it was an open chest surgical procedure, then there was a little stricter criteria as you weigh the risk versus the benefits. Now, some of our partners can go in with a catheter and deliver a patch across that and seal
Close
it
it up.
off. Yeah.
It's amazing. 85-year-old, what could be causing heart to fibrillate at random?
That could be atrial fibrillation. So as we've talked about before, unless they're talking about sometimes they have it, sometimes they don't.
I think that's it. The at random. Why is it happening?
So it comes and goes.
Chaotically.
Yeah. So it comes and goes.
Sporadically.
Yeah. Nobody really knows why it comes and goes in some people and not in others. But it can be fluctuations in blood pressure, alcohol, could be due to. It can just be, we may not have the answers to why it comes and goes. From my perspective, that's actually a good thing because it's easier to control when it comes and goes than when it doesn't.
Yeah, we like that. Clip, is it recommended to have a clip surgery to stop the backflow of blood in the heart? I don't know what a clip.
E-clip, I think.
Oh.
Yeah, it's again, we're venturing into structural cardiology, and
Okay, so show us where the clip would be.
so the mitral valve is this valve that separates the left atrium from the left ventricle, and the mitral valve is here. And typically what happens is one of these leaflets, and classically the posterior leaflet, prolapses, either because this heart muscle's been damaged here in the support structure, which looks like a parachute, becomes interrupted, and so one of these leaflets will prolapse back into the ventricle and not meet. And so one of the surgical remedies in the old days is called a Fiore stitch, where they would open the heart and place a stitch and sew that in between, so the leaflets coapt like that. You put a stitch in the middle, and then blood flows around either side. The side effect is you can get narrowing of that artery doing that. Well, now, if you come retro through the aorta backwards with a catheter, come up here, and while the heart's beating, you clip that and do this with a catheter and basically staple it together, then you can accomplish the same thing without an open heart.
Wow. And it works?
It does. We've not embarked on that adventure, but it's complicated. One of the big reasons to do it is if you have poor heart function, this artery dilates and these vessels, they just can't coapt and they stretch and dilate. So it's done on people who are really sick, have a lot of problems. They're not a surgical candidate.
There you have it.
It's technically challenging.
Right. Here is Facebook question. I've been diagnosed with acute coronary syndrome. It's a serious condition or not? And would diet help? What's acute coronary? Is that just recurrent chest pain, angina?
That's the new plaque rupture. You got cholesterol in the artery wall. It ruptures. You got a new tear in the lining of the artery. You get a blood clot. That blood clot's waxing and waning. The flap's waxing and waning. Some of the time it resolves. Some of the time it seals off. Most people will give you a history of that accelerating pain in retrospect.
Okay.
After a heart attack.
Tough one. Pulmonary hypertension and its relationship with the heart. Pulmonary hypertension.
Either of us is supposed to try that. Pulmonary hypertension means that, and I'm not a pulmonary hypertension expert. That's usually the people that are heart failure experts look at that.
You treat it with Viagra.
Yeah, treat it with Viagra. Let's sum it up that way. But basically what it means is this is the pulmonary artery, blood coming out of the right ventricle going to the lungs. Lungs are attached, okay? And what that means is that for some reason there's high blood pressure in the in the vascular bed inside the lungs. And we can get a sense of how high that blood pressure is by looking at an echocardiogram. We can sort of get a sense of how high it is. And then it can be due to a lot of reasons. A lot of times it's because you've got a bad left heart and there's high pressure in this left atrium, where I've said that the blood drains back to the heart through these pulmonary veins, and this gets reflected and causes high blood pressure. Other common causes are sleep apnea, smoking, emphysema, chronic bronchitis.
And that big, bad illness called idiopathic.
Idiopathic means the arteries themselves are actually clamped down and causing hypertension. That's a very rare, very serious disease.
But the interesting thing is that you tell it by the echo, looking at the right ventricle, the tricuspid regurg leak, and
if you're really concerned, Ray will stick a catheter up here and measure the pressure directly. Yeah.
right. 96-year-old with atrial fib for 3 years takes Tenolol for her, but her atrial fib comes back with any exertion. Is there anything she can do to manage the atrial fib? There are other drugs for atrial fib.
Other than atenolol. In fact, often I don't tend to use atenolol in people that are 96 because atenolol is cleared by the kidneys, so I tend to use metoprolol because it's cleared by the liver. When you're 96, your kidney function tends to decline almost no matter what you do. It could be that your heart rate is well controlled when you're sitting around having coffee and things, but when you get up and try to do activity, then your heart rate jumps way up, and then you notice it. So you either need more medicine for rate control, which means that your heart rate might get to be too slow when you're not doing activity, or we could use alternative medications for that.
I like Cardiozem rather than the beta blockers. What do you think?
Well, I think you can kind of use either or. If people have a weak left heart function's weak, I don't use Cardiozem, I use beta blockers because they need it anyway for the weak heart. Young patients tend to really not tolerate beta blockers like atenolol or metoprolol. They get very fatigued. Switch them to Cardiozem, they feel much better. Elderly patients, it's kind of a hit and miss either way, whichever one works.
Are you ever using DIG anymore?
In people that have poor blood pressure, I'll use DIG, or if I'm already using the other things, then I'll go into shocks.
But it drags those 90-year-old people down. 68-year-old from Brookings who doesn't have any heart problems, does 1.5 hours of exercise every 5 days a week, is a vigorous exercise in a 68-year-old. Dangerous, or is it helpful? Ray?
I'd say it's probably helpful. It's burst work is, what really gets people is when you watch TV and eat pizza for 9 months of the year, and then you think you're going to go hike for 7 miles chasing a pheasant.
Yep.
And you can't do that.
You can't do that. You got to be right. You need to be in shape so you can hunt those pheasants. Facebook, 68-year-old diagnosed with Wolff-Parkinson-White syndrome, had ablation 20 years ago, hasn't had symptoms for 15 years. Still need to be concerned about WPW?
Well, so WPW
Yeah,
is...
what is it?
So, are we green or are we red here? So here's your sinus node, and this is your body's biologic pacemaker. It fires off, starts your heartbeat. It's supposed to come only through this AV node to be able to conduct electrical signal down to your lower chambers. Some people will have a little sleeve of muscle tissue on one of these valves where some electricity can swing through here and directly activate the lower chamber. And what that physician did is they came up, let me see if I can, and they ablated that muscle tissue right there and got rid of it. So you can see that on the electrocardiogram that is gone, and if it's gone, then they're cured,
All right. So this person is cured?
provided they don't have any more conduction through that pathway there.
Well, it's been 15 years.
And as long as their EKG is normal, then yep, should be cured.
54-year-old woman with a heart attack last year, had angioplasty and stents placed, had lifestyle changes with exercise and diet. What can I do to reduce the risk of heart failure down the road? What is the anterior wall of where is the anterior wall of the heart located? Ray?
Anterior is the dictionary thing again. The anterior is the front of the heart.
Oh. Here.
So typically, did we have a coronary diagram? So it involves typically the septum and the front wall, and it would be the wall that you see in front. And this is our 4 chambers basically looking here, but supplied by this wall, this artery, the anterior descending, which means the artery down the front of the heart, and it typically supplies the septum as well. So the things to do would be, if there's going to be a problem with that stent, it typically occurs within around the first year. And as that heals and seats in there, then it becomes secondary prevention. So you want your LDL cholesterol under 70, you want to get to your body weight, you want to control your diabetes, you want to stop smoking, and you want to exercise.
Explain different symptoms of heart attack in men and women. They're different. They're different birds.
I think they're different because they present in different times in their life, and women tend to have a delayed presentation from 20 years after menopause, whereas men start 20 years after 20. And typically women are smaller, and so they'll often present with more severe diffuse disease, and so they get more shortness of breath. But I think if you listen to a lot of people, they will all come in with their share of somewhat atypical pain. You know, dental pain but it's related to exertion, those sorts of things.
So they don't, the classic, I've got an elephant standing on my chest, it goes into my neck, down my arm, that occurs about 30% of the time.
I don't know if I have a good number for that. Yeah, men will have an elephant sitting on their chest, and women will have a brassiere that's too tight.
That's interesting.
And when you say,
and there it is, that's the difference.
if you ask them about chest pain, a lot of patients will say, well, I haven't had any pain, just heaviness or tightness or something
tightness.
like that. Yeah.
65-year-old from Moorebridge, comment right on spot with atrial fib, loves the show. Yay! Grandson, 21, faints, good health, feels off before shower, feels faint in shower, but loses balance when he gets out to try and relieve this fainting. Does this have something to do with the heart? So he faints in the hot shower.
Oftentimes that's what we call a vagal episode. So people, when you start to feel warm or you get in a warm situation, or if you've got nausea or something like that, it's really just kind of a profound reflex is what I tell people. And your body has 2 reflexes, if you want to simplify it, either the adrenaline rush, where you're out running from people always say running from a tiger, or there's the anti-adrenaline rush, like when you're going to bed at night and you're tired and everything slows down. And so oftentimes when passing out happens in the bathroom, it's that anti-adrenaline rush, and your heart rate and your blood pressure both drop at the same time, and people can pass out.
And this guy, I think, has been on seizure medication, so it probably made the pressures lower.
If your so you can have a seizure if you pass out and your blood pressure is low and you don't get enough blood flow to your brain, you can have a seizure.
But the seizure medicines will set you up for blood pressure dropping easily.
True, very true.
Make it
so
worse.
that seizure versus cardiac is a very difficult thing to sort out sometimes.
What is a sick sinus syndrome?
Sick sinus syndrome is when your sinus node is not firing off fast enough or not regular enough. So if it just kind of stops, or if it just is firing up very slow, and you start to feel that, you're tired, you're short of breath, you're weak, you get on it, and we can put people on a treadmill and their heart rate doesn't go up. That's sixth sense syndrome.
And the last question. 75-year-old with pacemaker taking prescribed heart medicine and losing weight. Does the combination of pacemaker and medications cause weight loss?
You'd ask about digoxin, because sometimes when that dose is high, they'll have a anorexia or loss of appetite.
And they don't feel good.
Yeah.
Not the pacemaker.
And it isn't the pacemaker, unless the weight loss is because the edema is now going because they had heart failure.
Could
That's
be.
much better with the pacemaker. Can't tell you how much I appreciate your time and your expertise, and we really had a lot of questions. Thank you for your patience here. Thank you for joining us on our website. We appreciate all your questions and the opportunity to answer them. And until next time, stay healthy out there, people.